Jai Hind guys, today we shall be talking about lumbar puncture, but before I describe the standard indications and the contraindications, it would be prudent to talk about the lumbar puncture needle per se. Yes, we do have a color coding available for lumbar puncture needles as well, but you don't need to remember all of this. All I want you to remember is that in adults, we will be using 20 to 22G needle. Most of the literature supports the usage of 22G needle, which would be having a black hub. This superior needle would be called as Quincke's needle. The cutting edge of this is really sharp. Therefore, the chances of post-lumbar puncture headache would be relatively higher, and the length of this black hub Quincke's needle is 90 millimeter. However, in some cases, you might have to do repeated lumbar punctures as well. Now, what is that situation or condition where you might have to repeat lumbar puncture again and again? That could be carcinomatous meningitis. I will describe subsequently before you how many taps that you need to perform in a patient of carcinomatous meningitis before you say that okay, this is either negative or positive for carcinomatous meningitis. But because of recurrent trauma, it would be recommended that you use the needle with the orange hub, which is 25G. This is called as Sprotase atraumatic needle. And as the name suggests, atraumatic needle, the incidence of post-lumbar puncture headache would be lower. Now coming to the indications, the standard one would be meningitis of various etiologies. It could be bacterial, viral or fungal. For subrectal hemorrhage, we have very good imaging techniques available. So for routine diagnosis of subrectal hemorrhage, you don't need a lumbar puncture. You see, if you are in a peripheral center, you do not have imaging facility available and the patient is also presented late after 24 hours, then the RBCs are gonna break down to produce bilirubin that will produce a xanthochromic CSF. So it's only for a delayed presentation of subrectal hemorrhage or a delayed arrival of the patient that lumbar puncture would be required. The third scenario where you need to do a lumbar puncture is normal pressure hydrocephalus. Here you read about what is called as Hakim's triad. HAKIM. Hakim's triad would be having dementia, ataxia and incontinence. We would be removing about 30 ml of CSF and you will notice that after removal there is a marked improvement in both the gait as well as the cognition ability of this patient. For the fourth indication, I'm not saying that it will help in diagnosis, it will only be of supportive evidence in demyelinating disorders like Guillain-Barré syndrome, though obviously we need electrodiagnostic tests here. Then comes the aspect of carcinomatous meningitis that I was speaking about earlier. You need at least 3 serial negative taps to rule it out. And never forget this basic rule. Do not delay antibiotics and steroids in a suspected case of acute bacterial meningitis. Everything else can be done later, but antibiotics empirical should be started within 1 hour of admission of a patient of acute bacterial meningitis. Coming to the contraindications, the absolute ones, first would be local site infection, then is going to be CT evidence or midline shift, or there could be loss of suprachiasmatic cisterns, there could be a posterior fossa mass. Then comes coagulopathy. You will notice I'll be talking about coagulopathy in both the absolute one as well as the relative one. In absolute one, I am talking about dire straits. What I mean by dire straits is platelet count less than 20K or INR is in excess of 1.5 or heparin has been given in previous 24 hours, then you will definitely have to defer the procedure. Another contraindication for completion would be a lumbar vertebra trauma. Compare this with relative contraindications now. First would be raised ICP. How would I pick it up? They would be deteriorating consciousness in a patient. They can be development of posturing, brainstem signs in the form of pupillary signs or recent onset seizures. Then would be coagulopathy. Once again, I have put it in both absolute as well as relative because you as a clinician will have to take a call on whether you can do the procedure. I mean, the benefits outweigh the risks, or is it the risks which are more than the benefit which will decide your final decision. And a case of a brain abscess, because anyway this can contribute to raise ICP, as is a relative contraindication. Coming to the site assessment, you can wear non-sterile gloves and you have to locate L3, L4 interspace by palpating the left and the right posterior superior iliac spine and then moving medially towards the spine. Here a usual controversy would come up is that in some books it is written lumbar puncture should be done at L4, L5, some books it is written L3, L4. Well, you can palpate both the spaces, whichever is larger. Mark my words there, whichever space is larger is the site from where lumbar puncture can be performed, and in majority of people both men and women of any race, it is L3, L4 space that is relatively wider as compared to L4, L5, which means that in a question, if both are given, then L3, L4 should be answered. You can mark the side with a thumbnail. You can use maybe the back side of a needle cover and put an indentation on the skin, or you can use a marker to highlight L3, L4 side. Now coming to the pre-procedural checklist, just like when you board a flight, you are seeing pilots who are doing last minute check of the aircraft. Similarly, you need to ensure that the informed consent of the patient has been taken in local language with the signature of the patient, and the copy of this should be stored in your phone device. You very well know that nowadays courts in India are penalizing doctors for something as simple as that a tubectomy of a patient failed and the doctor was made to pay the damages not because the tubectomy failed from the technical perspective. It is because the doctor could not produce the records that he had informed the patient of the fact that tubectomy can fail. In the court of law, he was asked, do you have documentation of this fact? The patient told that, okay, this doctor did not tell me, but if you have documentary proof, then if anything goes wrong, you definitely can say that the consent of the patient was taken with respect to the mishaps that can occur with every procedure. And I would recommend you, wherever you are in a private setup or in a government setup, this should be a standard operating protocol from now onwards. Now change on to the sterile gloves. Open the plastic tubes for collection and arrange them upright. In most of the centers, we take about, in 3 tubes, we'll be taking the sample of the CSF, though classically it is recommended that you should take it in 4 tubes. You see, that will just increase the burden of the hospital. So in most of the places, you will notice 3 tubes being used. I'll tell you subsequently in which tube, which sample will be preserved per se and would be sent to which department. Assemble the stopcock on the manometer. Now in our case, we did not have access to a manometer, so we have not demonstrated that, but yes, once available, the opening pressure should definitely be checked, and draw the lignocaine in a 10 ml syringe, because most of the standard kits would be having a 3 ml syringe, but you might be having a requirement of much more higher amount of lignocaine in some patients. So it's always a good idea to achieve good amount of local anesthesia, because lots of time you might have to withdraw the needle a bit and then push it a little more, and therefore it can cause a substantial amount of discomfort in the patient. Position the patient in lateral recumbent position. Use skin swabs and antiseptic solution to clean the skin in a circular fashion starting at L3, L4, and then include the interspace above and one below it as well. Before application, warn the patient that the solution is cold, because especially in a cold winter, this cold antiseptic solution in some patients can be really unnerving. Once done, now you are going to use a sterile fenestrated drape that would be deployed on the patient, and you can recheck the site where you will be giving local anesthesia to the patient. You can notice that when you are planning to give local anesthesia to the patient, the simple prick of the needle can make the patient buck and make him uncomfortable. So it's important that somebody should be consoling the patient and supporting the patient emotionally. You can be using a 25G needle initially for producing the skin wheal, and then you can change it to 20G longer needle for anesthetizing the deeper tissues. Stabilize the 22G needle with your index finger, orient the bevel up. The objective is to separate the longitudinal dura fibers rather than cutting them. The insertion of the needle has to be slightly cephalad and directed towards the umbilicus. The characteristic pop sensation may or may not be heard. The sterlet is withdrawn after a depth of about 4 to 5 cm and observed for fluid return. If there is no fluid, do not panic. Replace the sterlet, advance or slightly withdraw the needle, and you would usually be getting the CSF as you can see right now. In our case, we had bypassed the step of checking out the opening pressure with a manometer, but in case you are checking out the opening pressure with a manometer, ensure that the legs of the patient are straightened. Else, if the legs of the patient are flexed with the knees touching the chest, there would be a false elevation of the CSF opening pressure. Now, how much CSF should you collect every time? It should be approximately 10 drops of CSF in each of the plastic bottles. If the flow is slow, ask the patient to bear down as in Valsalva maneuver. Alternatively, you can rotate the needle by approximately 90 degrees and you will get a good flow of CSF. In the first test tube, you would be sending the sample for protein and glucose estimation. In the second test tube, you will be sending the sample for gram stain and culture to the microbiology department. And in the third test tube, you would be checking out the cell count and the differential count in the CSF. Once the sample has been taken, you will replace the stellate, remove the needle, apply a sterile dressing, and then subsequently place the patient in a supine position. Lastly, we shall study regarding the complications of lumbar puncture procedure, and the usual one that is encountered is a post-spinal lumbar puncture headache. This occurs in approximately 20 to 40% cases and begins 24 to 48 hours after the procedure. The localization of headache will be mainly fronto-occipital and it will improve in supine position. The headache is self-limiting and usually resolves within 7 days. It responds very well to analgesics and caffeine, and God forbid if it does not, you definitely can use a epidural blood patch. The technical details of epidural blood patch have been described in the main video with respect to meningitis in the main section of the app. The second complication that can occur is a bloody tap. In fact, in lots of cases, almost 50% I can quote the textbook, our reports are false positive for red blood cells, because when blood will come, white blood cells will also come. Obviously, RBCs would be coming. There could be a dry tap occurring. This could be due to wrong positioning of the needle or due to dehydration of the patient. So that should be remembered definitely, that dehydration will contribute to dry tap during a lumbar puncture. Then can be infection, hemorrhage, and dysesthesias. One of the important reasons for this dysesthesias in the lower extremities of the patient is that if you try and withdraw the needle without putting the stellate back inside, once you've obtained your sample, you need to put the stellate back into the lumbar puncture needle and then withdraw the needle. If you try to do it just like that, the some of the nerve roots might actually get entrapped, which explains the dysesthesia component. And worst case scenario can anyway be that you have performed lumbar puncture and there could be a cerebral herniation, and this is one side effect that nobody can predict, and that is why I was saying that the documentation part of yours should be perfect. So these are the important details that I would like you to remember for this procedure. Thanks guys for watching this video, and I'll be back with another educational video very soon. Till then, keep hammering.